So starting with acute rheumatic fever, a short revision. It is an example of molecular mimicry. So the patient had a history of group A beta hemolytic streptococcal infection, either like pharyngitis, and after that the patient developed the symptoms of acute rheumatic fever that we are going to discuss. Here the patient developed antibody following the infection, and these antibodies are going to cross-react with host tissues like heart, skin, joint, etc. Now when these antibodies are cross reacting, why they are cross reacting? Because in this region the some tissue antigens are simulating like the group A beta hemolytic streptococci, so they are cross reacting with this host tissues. These antibodies are going to cross react and develop the symptoms. So to diagnose this acute rheumatic fever, we have modified Jones criteria, and in India we have moderate to high risk population. So according to that, the minor criteria are there. So we are just going to discuss the high risk population. We are not going to discuss the low risk population. Okay. So here, this criteria have some major criteria and some minor criteria. Now please remember, in major criteria we have 5 major criteria. Okay, the first criteria is pancarditis. It is not just a carditis. The pancarditis means involvement of myocardium, endocardium, pericardium, etc. So the patient will be having typically chest pain, and there will be friction rub. Okay, and this is very important. It may be a clinical or subclinical, and echo finding is suggestive of carditis, and that is what you have to remember. Pancarditis mostly involve the mitral valve also, and leading to mitral valvulitis or mitral regurgitation. Okay, and in mitral regurgitation you will find what, during systole the blood will back into the left atrium. This is what is mitral regurgitation. We will be having pansystolic murmur. Now please remember, we are discussing pancarditis, so it ultimately led to the left ventricular failure, and which is the most common cause of, or most important cause and most common cause of morbidity or mortality in case of acute rheumatic fever. Okay, and next coming to the arthritis, this is the major criteria. Arthritis involves monoarthritis, polyarthritis, or polyarthralgia. So here a word of caution is monoarthralgia is not considered as major criteria. You can see monoarthralgia is under minor criteria. Okay, so if it is any kind of arthritis, or if it is a polyarthralgia, is what is under major criteria. What you have to understand from arthritis is that, please remember, these arthritis are very much reversible, so complete recovery is possible, and their complete recovery is possible, and they are having great response towards aspirin. So if you treat them with NSAIDs, aspirin, so they are having great response to aspirin. Okay, and these arthritis are migratory in nature. So this is what is typically known as migratory polyarthritis. One joint is involved, then other joint is involved, and previous joint manifestation is resolved. So one after another is involved, what is migratory in nature. So 3 points: it is migratory polyarthritis, it is completely reversible, and great response to aspirin. Great response to aspirins. Okay, next coming to Sydenham's chorea. This is the third major criteria, that is Sydenham's chorea. Now please remember, chorea, it is obviously an involuntary movement disorder, and this is the late finding. Okay, the earliest finding is carditis. Please remember, it is earliest finding, and also this is the most common finding. It is the earliest finding, and it is also the most common feature of ARF. Okay, and if the patient developed permanent valvular damage, it becomes the most serious. Okay, next is Sydenham's chorea. It is involuntary jerky movement. It is an involuntary jerky movement which is semi-purposeful in nature. What you have to remember from chorea is, patient might be giving some features like milkmaid sign, milkmaid grip sign, that is all. When the patient is asked to grip someone's finger, there will be alternate tightening and loosening of grip, is what is your milkmaid sign. And also you will see that the patient cannot hold the tongue in protruded position. When the examiner asks to protrude the tongue, is what is known as darting tongue sign. So milkmaid sign, darting tongue sign, these are seen in Sydenham's chorea, that is the late manifestation. The earliest is the pancreatitis, and this is self-resolving. And next is coming to the erythema marginatum. Erythema marginatum. Erythema marginatum is, what you have to remember, is a non-pruritic skin conditions where this patient will be having erythematous lesions with pale center which are non-pruritic, and they will coalesce each other to form a serpiginous rash. Next is subcutaneous nodule. It is painless nodules, mostly seen on the bony prominences like elbow, the seen, and these regions, and they are non-painful and associated with carditis. Means the presence of nodules will be associated with high risk of carditis. Okay, so these are the major criteria. Minor criteria you have: for the high risk population, you have fever, monoarthralgia, ESR, and CRP. Okay, they are considered one criteria, and prolonged PR interval. Okay, now please do remember, if you are considering carditis as a major criteria, so PR interval prolonged is not considered a minor criteria. If you are considering arthritis as major criteria, so monoarthralgia won't be considered as a minor criteria. Okay, diagnosis of acute rheumatic fever will be possible only when the essential criteria is met, and that is presence of ASO titer. The high ASO titer should be present. Okay, obviously you can do a throat culture, and throat culture may be positive, but at that time, as it is an immune molecular mimicry, the agent cannot be detected in the throat swab while the acute rheumatic fever symptoms are there, so it is generally not done. So elevated ASO is what is preferred investigation. So the patient will be giving a preceding sore throat. Okay, and there will be increased ASO titer in the background, and then you will be assessing the major and minor criteria. Presence of two major criteria alone or one major criteria with two minor criteria is what makes the diagnosis of fresh acute rheumatic fever. For the recurrence cases, three minor criteria, okay, presence of three minor criteria will make the diagnosis also. Okay, so but in each and every condition, this essential criteria, that is increased in ASO titer, has to be present. Okay, now how are we going to treat this patient? Remember, the prophylaxis that we give is penicillin G. Okay, what we give is penicillin G. It is, what we give is 4 times a day for 10 days. 4 times a day for 10 days is for the treatment. Okay, for the treatment. And this is obviously parenteral IV. Pen G is given IV, na? For oral, there is a variant, that is what is known as Pen V or penicillin V. That too is given 4 times a day for 10 days. Now, this is a very important condition, so the secondary prophylaxis is of great importance. Now, if the patient is without carditis, so we have to give the prophylaxis with penicillin G or penicillin V. We have to give this prophylaxis for 5 years. Please remember, we have to give the prophylaxis for 5 years. So 5 years or till 18 years of age. So whichever is longer, okay, whichever is longer, you have to give till, like if the baby is 12 years old, so 12 plus 5 is 17 years. Okay, and 12 to 18 years is 6 years. so then I'll give 6 years. Okay, because till 18 is 6 years, and agar 5 year is considered, then it will be 17 years. So whichever is longer, that is preferred. If the patient developed carditis, with carditis is there, then it is 10 years, up to 10 years, or 25 years, whichever is longer. And if the patient has already established rheumatic heart disease, and or the patient has had undergone valve replacement therapy or valve replacement surgery, then up to 40 years what we consider, that is ideally is I have to give it for lifelong, but what is given is 40 years. If the patient is allergic to penicillin, then we have to start the patient on macrolides like erythromycin. Okay, so macrolides, uh, we have to start the patient on macrolides, that is erythromycin 250 mg 4 times a day for 10 days. Okay, penicillin G or oral penicillin V also the same dose, 4 times a day 250 mg. Understanding? Now this is what is treatment, but for carditis we can start the patient on prednisolone, the steroids. Okay, for arthritis, as I told you, they are having great response to aspirin, so we can start the patient on aspirin also. Okay, so this is what is acute rheumatic fever.